This is the Big Ideas Theater. I'm Ed Highland. We're here at AARC Congress. I'm joined now by Garry Kauffman, talking about many things. Garry, good to see you once again.
Thank you.
Had a chance
good to see you.
Chat last year. Very different topic this year, talking about challenges facing respiratory care as a profession, and making that transition from World I to World II. Explain for us.
Well, if I could start with the second one. If you remember, the Affordable Care Act, great that it was about this many pieces of paper. So what I did is just took a couple points of that are relevant to respiratory therapy. So the definition of World I is that's the way we grew up. That was a fee for service. The more we did, the more the hospitals charged, and life was good. Or maybe it wasn't, we just didn't know any better. It was simple. There was no value, there was no patient safety, no advocacy in that world. It wasn't bad, it was just different. The transition we're in now is to move that and actually leave that on the shore and get in the boat for World II, which is value-based. And I'll talk about that a little later, what that means, but hospitals are now rewarded or penalized if they don't achieve certain targets for safety and value and clinical quality. That's really challenging to hospitals and providers and clinicians such as RTs. It's a whole different world.
Well, let's talk a little bit about some of those changes. I mean, you mentioned that all this is coming. We know it's coming. Different administration, different philosophies coming into play here. What are some of these big challenges we're facing?
There's really three themes. The first is cost, and then quality and patient experience. In no particular order, but maybe there is a particular order there, Ed. The first is getting a handle on cost. We know if we don't change our spend rate for healthcare by the year 2040, we will spend about 34% of our gross domestic product. That's just not attainable, not affordable. So what the executives and clinicians and government folks are talking about, how do we manage costs? Things like reducing length of stay, reducing readmissions, reducing unnecessary therapies. And that strikes home to RT, because that's our opportunity to basically take a look in the mirror and say, is there scientific evidence that supports that? If so, let's go. If not, we've got to move away from that. The second area, which I hope is really just as important, if not more so, is quality. How do we measure quality in this value world? It's not busyness, it's not treatments done, it's the outcomes of that. And last, and certainly I would think first, is the patient experience. That's the third rung of the IHI triple aim. And I was talking to an executive about this, and I challenged them, do you have a patient on every single hospital committee? No, why not? Well, we never did, because we didn't engage patients and family members. You're seeing hospitals have former patients and family members on every committee, from mortality, morbidity to satisfaction. That's a brave new world. Scary, but it's a world that I think is perfect for respiratory therapists.
So we've got some value-based issues going on here. There's also some themes I know from your presentation that you gave here at AARC Congress. Can you kind of straighten some of this out? We've got a lot of points we're trying to get here, but you've got them kind of bullet pointed for us, if you will.
Well, there's four themes, and it is the three that I mentioned before, and a fourth one is collaboration. So let's just use some examples of that cost thing. If you remember, for the last, forever, 100 years, patient is admitted to the hospital. Well, person's admitted to a hospital, becomes a patient. We fix them, we give great care, and then they are discharged. That's not World II. Being responsible for their care and their health, maintaining health, not just treating illness, across the care continuum. So what we're seeing is hospitals collaborating with post-acute care providers, and that's the collaboration part. And just 2 weeks ago, CMS released a list of penalties for skilled nursing facilities. This is a new world where they are now being penalized financially if residents in their care are admitted to the hospital for above a certain target. That's a game changer. So that's one of the collaboration issues. What some folks are looking at is, now that we are charged with transitioning the patient, not discharging, but transitioning, we've got a whole new array of partners. Skilled nursing, LTAC, home health durable medical equipment. We are now charged with managing their care, maintaining or improving their health across that continuum. Additional area of cost control, we're looking at new patient care models. And this can be unsettling, but it allows the respiratory therapist to say, let's take a look at where we add value, document it and communicate it. If we don't add value in a particular service, let's find another area where we do. The quality improvement, telemedicine is just making tremendous strides. Not a lot of evidence yet at the highest level, but certainly everyone's on board with that. And that's a great role for a respiratory therapist to play in the telemedicine RT, to be able to Skype or whatever technology with that individual in their home to say, Ed, you were discharged by Dr. Susan Smith, and you were given a prescription for an inhaler. Show me how that works, Ed. And when they don't procure that, it might not be that they weren't shown how to use it. It may be they can't afford it, or they didn't have transportation to get to the pharmacy or doctor's office, or their literacy level, so-called social determinants of health. We know that healthcare in that pie of health is a thin slice, what we do in hospitals, but social determinants of health and genetics, that which we really don't address as clinicians, but those social determinants of health have really never been addressed by acute care hospitals and clinicians. Poverty, literacy, transportation, domestic violence. We are now charged to help individuals circumnavigate the healthcare continuum from the hospital to home, nursing home, different levels of care, and make sure they can get to their doctor.
If there's any advice you can give to RTs now, I'm tapping into your experience, if you will. You've gone over the changes in guidelines. We know the regulation, things change along the way on a fairly regular basis, but it's the planning process that becomes so difficult because the crystal ball is a bit cloudy as to exactly what's going to change in healthcare at what time, based on sometimes the whims of the political element.
Right.
So how do you plan for year 2, for example? You can look at year 1, but how do you plan into year 2 and beyond when you don't really know what's going to happen?
Well, a couple comments. If anyone says they know the answer, run away, because no one does. That murky ball, we can't even find that some days. I think the first thing, it's sort of a litany. 1, make sure we establish our value, either at the highest level of evidence or best practices. 2, we need to communicate that to the federal government, to our state governments, Medicare, Medicaid, our physician and nursing colleagues. It's one thing to know what to do, but it's quite another thing to be able to implement it. And quite honestly, get partners in this, because respiratory therapists are small in number compared to nurses and physicians, so having that collegiality. 3rd, we need to be able to communicate the message of our value to senior executives, consultants, and the government. Blue Cross Blue Shield, other commercial payers. We're one of the best kept secrets in healthcare. Those who know us know that we do a good job in the acute care hospital, but not so much outside the hospital in the post-acute care world. And the 4th is let everybody know. Don't hide the candle. Let everybody know the value that we provide, and we're up to it. And I've said this for years. These are scary times. World 2 is going to be World 3. Z-Dog told us World 3 might be a better one. And there is no better time to be a respiratory therapist than right now. If I didn't believe it, I wouldn't be here talking to you, Ed.
With those words of wisdom, thank you.
Thank
Garry
you.
Kauffman, appreciate it so much. You've been watching the Big Ideas Theater here at AARC Congress.